So I was on faculty in the medical school from '94 to '99, and it's really nice to be back. Haven't really spent a tremendous amount of time back here, and at the time I really got my start here. As a matter of fact, I was telling Harold before that this room, I'm having a very intense sense memory of taking Mike Sawson's class on human service organizations in this room.
Wow.
Maybe he's here for all we know, if you believe in that sort of thing. But it's really a pleasure to be back, and I wanted to thank you all for the invitation. So my work, I am a clinician and health services researcher interested in addictions, and in particular interested in the system of care for addictive disorders, and thinking a little bit about how we create a system that really treats this family of disorders like the chronic diseases that they are. So that's a little bit what I'm going to talk about today. This is a family of disorders that touches many service systems, including the social service systems, the health system, which I've done a lot of work, particularly with NDATs and other projects around. And then today I'm going to talk a little bit about criminal justice. So I have a couple disclosures. I've gotten some in-kind medication from Alkermes. I've had a couple honoraria from Indivior and some travel and training from Braeburn. So here's where we're going to go today. I'm going to talk a little bit about how addiction is endemic in the criminal justice system, probably not news to most of you. We're going to speak about opioid use disorder in particular as a chronic neurobehavioral disorder. Then we're going to talk a little bit about medication treatment and how it works, particularly how it works by attenuating positive and negative reinforcement. For those of you who remember your Psychology 101, you can fall asleep during that part of the talk. Then we're going to talk about incarceration and why it's really not an effective treatment for addiction. And there's a section about how medication works a little bit, about why punishment and a lot of the things we do are not terribly effective. Then we're going to talk about high mortality for opioid use disorder when tolerance is lost, especially after incarceration, and then about some of the benefits of medication treatment and why I really think that that's the direction that we should really be pushing if we want to do something to stem the overdose crisis. So this figure should not be foreign to most of you. This is sort of a statement of the war on drugs in this country. And from 1980 to 2014, the inmate population in the United States increased 220%. In 2013, there were 2.24 million prisoners. That number has been relatively flat since then. Not rising at quite the same rate, but really we're not seeing reductions. And about, if you look at parole and probation, there are over 7 million adults in the US who are involved in the criminal justice system. And substance use disorders really are endemic. And really the war on drugs is a large driver of what we've seen. So drugs are implicated in 60 to 83% of offenses. About 40% of men and 80% of women have a nonviolent or drug-related offense. And in terms of the criteria for a substance use disorder, 44% of men and 52% of women actually meet criteria. And the stunning fact is that 80% of individuals in the criminal justice system who could benefit from treatment still do not receive it. When we think about opiate use, it represents about 20 to 23% of US inmates. substantial proportion. These are older data. It's actually closer to a quarter of U.S. arrestees have a positive UTOX for opioids. Similar numbers for jail inmates with regular use. So it clearly is a problem that is endemic in the criminal justice system, and presents a bit of a quandary for those who are working in that system, because even though it's been treated as a criminogenic problem, it really is a medical neurobehavioral disorder. So anybody know who this guy is? You're all U of C people. You know this guy, right? Anybody? Speak up. Skinner. So yeah, obviously you're a social scientist. There are very few psychology majors in this group. That is Skinner, yes. Who is it that gets an A here? Okay, you graduate with honors. Make sure that person gets honors. Yes. So, so this is a friend of mine here. They do a lot of these experiments here at U of C, these lab experiments in which we put a rat or a mouse in a cage, we give them an IV, we put a little morphine or cocaine, or you can name your reinforcing substance, and we sort of let them run free in the cage, and often by happenstance. I'll say it's a he. Is that okay? He will hit the lever and then go, whoa, that was pretty cool. I like that. So then what happens next?
Hits it again.
He hits it again. He goes, oh, I'm going to try it. He hits it again, and again he gets a little thing. And it's like, oh. So then what happens? He does it. He keeps hitting it, right? He keeps hitting it. This, so this is a process of learning. This is how we, I say we as animals, because I think everyone in this room is an animal, last I checked, how we learn. Again, we put a lot of stake as humans in our cognitive ability to learn, but really conditioned learning is a big part of the way we go about our everyday lives. And what this guy has learned is if I hit that lever, ooh, that gives me a reward. That feels really, really good. And that will be remembered, right? That will go into a part of the brain associated with conditioning and memory. And he will learn, if I hit this lever, I will get a hit of cocaine or opiate or whatever it is. And we've seen in these types of experiments that these rats will keep hitting, give up food, give up everything until they die, right? For this, this should not be unfamiliar. So that's, now if we had a different scenario in which we sort of had a metal lattice underneath his feet, right? And it was electrified, right? And same thing, every time he hits the lever, the electrified lattice gives him a shock. What does he learn? It doesn't hit the lever, right? So that's how we suppose that punishment works, right? Punishment works because if you hit the lever, something bad is going to happen. Now, what if I put the electrical field on all the time, and he's like going crazy, it really feels awful, and he hits the lever, and the electrical field turns off? He learns, right, that it's, and that they call negative reinforcement, right? There's an aversive that's taken away. That's sort of an important distinction we're going to talk about, because when we think about opiate use disorder, that's sort of how withdrawal works for people, right? It's an aversive that when I take the drug, it goes away. So he's learned this. Now what happens if, he's learned this, he's hitting the lever, hitting the lever, and I turn off the juice. I press this button over here, boop, and he no longer gets anything. What happens? He hits the lever, right?
He'll continue to hit it.
Hmm?
He'll continue to hit it, and he'll get the juice.
He hits it.
He'll just keep hitting it.
He keeps hitting it, and he's not getting high anymore. He's not getting any euphoria from it. So what will happen over time?
He robs a bank.
He robs a bank. No. Excellent. No. Well, no, what he'll learn is that that behavior is no longer reinforcing. It no longer feels good, so what's the point? And after a while, he'll hit it a couple times, and he'll learn it's no longer really working. And that's how medication works, right? And we're going to talk about that. So I want you to remember this guy. He's sort of very important to our thinking about addiction. The other part of this is that we're influencing parts of the brain that are involved in reward. So let me ask you a question. How many of you are enjoying eating right now? Okay. How many of you enjoy sex? You can edit that out of the thing if you want. Let the record reflect that everybody raised their hand, okay? These are the parts of the brain that really are engaged in survival, very primitive parts of the brain. Our little friend, the rat, has the same parts of the brain as we do. We put a lot of stock in these parts of the brain over here as making us human, our cognition, but really a lot of our behavior is determined in here. These parts of the brain, the nucleus accumbens, ventral tegmental area, hippocampus, amygdala, are all very much associated with memory and conditioning. And what happens is when you have chronic exposure to reinforcing agents like opiates or other drugs, there are changes that occur in these parts of the brain around conditioning that unfortunately are semi-permanent. They take a really long time to reverse. We see this is the mu opioid receptor here. And by the way, there will be a quiz on this afterwards, so be sure you take very careful note of this. But there really are changes at the cellular level and changes in gene expression that really explain the effects that we see within the brain. That's really, really important. And those changes don't go away just like that. Something to mind. So what we see, these are axial images from an individual with methamphetamine abuse, but it's sort of similar principle. This is sort of the axial. This is sort of the sagittal view, right, cutting through those parts of the brain. These are those same parts of the brain cut this way. If you were to take a chainsaw and cut my head like this, that's what you would see. What you see is the normal control. There are high levels of dopamine, the red in here, in those parts of the brain that are associated with reward. If you take somebody who's a chronic methamphetamine user and then you detoxify them, you take away their drug, what you see is that level of reward from dopamine does not return within a month. And we start to see it return within 2 years. So it really takes a very long time for those effects to reverse. The other part of this that's important in our story about opiate use disorder is to think about dope sickness. Now, how many of you have ever seen somebody withdrawing from opiates? Excellent. They were very happy people, right? So for those of you who haven't, I want you to imagine for a second, to give you a sense of what it feels like. I want you to imagine the worst upper respiratory illness you've ever had, okay? So I want you have incredible, your nose is running, your head is totally full and congested, you're achy all over, you're shaking, right? You feel really crappy. Are you feeling it? Everybody? You feel it? Now wait. Add to that the worst lower GI illness you've ever had, okay? So you have this upper thing, and now you're having stomach cramps, diarrhea, right? And you're curled up in a ball like this guy here, feeling aches and sweating and weakness and spasm and chills and shaking, and you feel awful. Are you guys feeling it? All right. Now, in the back of your mind, you have this knowledge that if I just take a little tiny taste of opiate, just a little smidge, it will all go away. This misery will all go away. And that's the power, sort of the powerful negative reinforcement effect of withdrawal. Now, withdrawal is not necessarily the sine qua non of addiction, because we do see it in people who have chronic opiate use for legitimate purposes. But it is a powerful factor in why it's so difficult for folks to recover from this disease. The other thing I like to emphasize is, particularly for lay audiences, is that addiction is not the same thing as dependence. And for those of you who are familiar with the Diagnostic and Statistical Manual, they really did us a disservice a bunch of years ago, because the notion of substance dependence was a classification. It's now, in the DSM-5, they finally now classify it as substance use disorder. But really, when we're talking about addiction, we are talking about what the American Society of Addiction Medicine calls the 4 C's: the compulsive quality of use, the impaired control, the continued use despite negative consequences, and the craving. And when we think about physiologic dependence, that really is the biologic adaptation to chronic use. So the 2 aspects of that are tolerance, which is a very important feature for you to understand when we think about this disease. It's a decreased effect of the substance after repeated use, or the need for an increased dose to achieve the same effect over time. So you keep using, you need more and more in order to get the same effect. But it's not just the need for more and more. It's also, you could use the same amount, but you need a more bioavailable route of delivery. So somebody may start off swallowing pills or snorting. Then they move to, by the way, this is the universal symbol for injection. They move to injection because it's more bioavailable. The other side of it is when you lose tolerance, and we're going to talk a lot about that today, you have a decreased need for the amount of substance in order to achieve the same effect. And if people go back to using the same amount they did before, they're at risk for fatal consequences, for overdose. And we talked about the withdrawal syndrome. Now, these are, as I said, are important features of this, of the addiction or substance use disorder syndrome. But just remember, in thinking about the diagnosis, it's really these features, sort of the compulsive use and lack of control, that really are the features that make the diagnosis. So, and we see this in the DSM. You see down here are the physiologic manifestations, and really all the other ones are about impaired control, social impairment, and risky use. So here's our guy again. So what goes into being a strong reinforcer or a strong aversive? So they say that whatever it is has to be salient. And the idea of salience is that it's something that's meaningful. And it's not meaningful in like the philosophical sense of meaningful. It's meaningful in the sense that it's something that you care about. The reward of feeling really good is something people care about. Severe punishment is something people care about. You know, if, I don't know, if whenever you used, I splashed you with water, that's a terrible example, but you probably wouldn't find that terribly salient. You'd be like, you know. Immediacy, what the criminal justice folks call swiftness. Are there any lawyers in this room, criminal justice folks here? No? So the notion of immediacy is if this guy hits the lever and 2 hours later he gets a shot versus if he hits it and I give it to him right away, which one is more likely to make him keep hitting it, right?
Right away.
Right away. Its immediacy is really important in terms of conditioning behavior. And then reliability. So reliability is the notion, if he hits it and nothing comes, he has to hit it like 5 times before something comes, versus if he hits it every time. He's more likely to repeat the behavior if it happens every time. Now, how many of you have ever, how many of you ever played a slot machine? Anybody? Do you get rewarded every time you play? You pull? Have you ever won? Anybody ever won? Never won.
A small amount?
A small amount. You've won a small amount. Yeah, so there is a ratio. The casinos they're very smart. They're obviously mathematicians who went to U of C. No problem. They reinforce you enough and a small amount that you'll keep pulling. That people will keep pulling. I think the ratio is like 1 to 7. 7 pulls. So keep pulling. A small amount. So enough to keep you doing it, but not so much that they lose money, right? Because I think they're in the business of making money. But certainly the more reliable it is, the more frequent you would win, the more likely you're going to pull. And as I mentioned before, if those properties are lost, the particular behavior would become extinguished. So if what was before immediate and reliable, he was getting it every time, if I turn it off and he doesn't get it every time, then that behavior, that expectancy that he has an expectancy that in his areas of his brain involved with memory and conditioning, he has an expectancy that if I hit this lever, something good is going to happen to me, right? If that doesn't happen, after a while, he learns that that behavior is no longer going to produce that effect, and so the behavior becomes extinguished. So let's think about what we're talking about today, drug use and crime. So when I take drugs, here I am, okay? The positive consequences I experience right away. I get the euphoria right away. If I rob a bank, I get the money right away, right? Positive, very strong, immediate positive reinforcement. And do I get it every time? Initially, yeah, right? I inject or I use. I get it every time. What about the negative consequences? Do I get arrested every time I use? Do I go to prison every time I use? Do I overdose every time I use? Do I get HIV? You get the point. And is it reliable? Even if I get arrested, the criminal justice system has its vagaries. The system is really delayed. It could take years or months till you have a hearing, and years till you're convicted. So really, if you think about it as the balance, there really is a very strong pull towards maintaining those drug use and crime behaviors as opposed to seeking, as opposed to forces that are working against it. What about the converse of that? Recovery and rehabilitation. So if I decide tomorrow that I'm going to give up drugs and live a life without them, will I get a good job and housing and my relations back and my health? Will that come back right away? It's delayed, right? It takes time for those things to happen. And does it happen every time? Well, I can say in life for anybody, you can't guarantee. There are no guarantees in life. By the way, there are no guarantees in life. You get anything out of it, there are no guarantees. So really, the positive consequences of recovery and rehabilitation are delayed and unreliable. What about the negative consequences of recovery and rehabilitation? So in order to come off, I have to go through withdrawal and craving. I'll experience stress, I'll experience dysphoria, I'll feel bad, I'll have to give up my friends. Does that happen for everybody? Yeah, unfortunately it does. It's manageable, but it happens every time. So again, the system, in a sense, is, to quote our president, the system is rigged. It's rigged in favor of continuing drugs and crime and against. So we have to really think about these, the systems we have, what are we reinforcing? And how can we sort of design a system that's going to rebalance, if you will, the incentives that folks experience? So one of the tools that I think is really powerful for opiates and alcohol to some extent, we're going to talk mostly about opioids today, is medication treatment, which really work by attenuating positive and negative reinforcement. So there's a lot of talk, you'll hear people say it's substituting one drug for another, it's another addiction, all of that. I'm hoping you'll walk out of this room having sort of a different view of how medication really works. So this is a very famous slide from one of the original papers by Dole, Niswander, and Creek. They did the early methadone experiments at Rockefeller University in describing how methadone worked. And so this was sort of, what does it feel like to have opiate use disorder? So there are three functional states that the opioid user experiences. You can feel sick, which we described just before, right, is that withdrawal state. You can be high, which is a state of euphoria. Or you can be straight, which is how presumably you and I feel right now. Does anybody feel high right now? Okay. Anybody sick? Well, thank you. So what happens is the person wakes up in the morning, they're feeling sick in the morning, they have to use, and early on in their addiction career, they're still getting high, so they pass through feeling straight, they get high, they're feeling the euphoria. Later in the day, they start to come down. They're like, okay, I better do something before I get down in here. So they inject again or use multiple times a day. And what you find is that using these short-acting opioids, there's a requirement to use multiple times per day. The thing that's notable is, most of the time they're either feeling sick or they're feeling high. They're spending very little time feeling normal. What happens as time goes on, they develop tolerance. They're no longer getting high. And by the way, this is the time where people will come to see me in my clinic. I'm no longer getting high. All I'm doing is using to feel normal. So what they do is they wake up in the morning. By the way, this dotted line represents many, many months or years. They're using, it gets them feeling functionally straight, but they're no longer getting high. So, the thrill is gone. And at this point, they decide, okay, I need to get treatment. So the point of this slide is they spend very little time in the normal state. So what medication treatment does is it attenuates the reinforcement. So remember the reward? Here's my symbol again. My reward is immediate and reliable, right? If I give a medication, the idea is to make that reward of that behavior less immediate and less reliable. And how does that work? So here is, these are PET scans of individuals given different levels of buprenorphine. Buprenorphine is a medication that we use to treat opiate use disorder. We'll talk a little more about it later. But at different doses, 0 milligrams, 2 milligrams, 16 milligrams, 32 milligrams. The usual therapeutic dose is usually in the 16 milligram range. Again, this is your brain cut with a chainsaw across the top, right? Axial view. And what they do is they give a radio-labeled morphine analog, so it's a type of morphine, and they're seeing whether or not it gets into the brain, right? So you give you pre-medicate somebody with the buprenorphine, or in the case of the bup 0 with placebo, and then you give them this radio-labeled morphine. And what you see is when there's no buprenorphine on board, the morphine is getting into the brain. This is the sagittal view over here, and this is the axial view. And you can see those parts of the brain we were talking about before are lighting up like, well, it's green. I would say it's like a Christmas tree, kind of. Green and red, like Christmas, because the morphine is getting in there. And so that individual presumably is not blocked and would be getting high. And what you see progressively is as we give higher and higher doses, the amount of green and red decreases. So less and less of the morphine analog. And by the way, morphine, for those who inject heroin, heroin is converted in the brain to morphine. They're actually, the reason heroin is synthesized from, actually synthesized from morphine is to make it more lipophilic to cross into the blood-brain barrier. So you get faster onset. But in point of fact, the mechanism really is through morphine. So what happens is when you're up to 16 or 32 milligrams, that reinforcing effect is blocked. And at the same time, you hope to stop the negative reinforcement. So you want to do something about that awful feeling of withdrawal that folks have. And so what happens is over time, this will extinguish the expectancies and the conditioned responses. So what will happen, just like that, remember our mouse or rat hitting the lever? And I know we don't like to think of ourselves as like rats or mice, but we are animals. Eventually, the behavior, the drug-using behavior, and all of the other antisocial activities associated with it will become extinguished because that reward is blocked and the negative reinforcement is attenuated. So what happens is you give it once a day. It's long-acting. It's given orally in the morning. They feel straight. They're blocked. Okay? If they try to use, here's somebody trying to use, the receptors are all really occupied. It's very this is the universal symbol for a receptor, right? Mu receptor. Here is my, I've occupied the receptor. It has a very strong affinity, a strong binding to the receptor. And then when the morphine comes around, or the oxycodone or whatever, it can't kick it off, right? And so they get very little change in relative intrinsic activity, so they're not getting high. And so what happens over time is that behavior is extinguished. That's how it works. Here is it in thinking about the percentage of mu, and the mu opioid receptor is the major receptor where opioids work in terms of both pleasure and analgesia, pain relief. If you think of us giving a full agonist like methadone, when somebody takes and it's fully occupying these receptors, what makes you high is the speed of the relative change in intrinsic activity. So what happens is if you give, say, heroin or morphine on top of it, which I'm doing right now, you see there's a very little change in the amount of relative activity. So the euphoria is attenuated, and the behavior becomes extinguished. So there have been decades of randomized trials. When I talk to cardiologists, I say, this is even better proven than like beta blockers. This is one of the best proven medications in all of medicine. Why are there so many studies? Because people just don't want to believe that it works, but it really does. This is a review from a Cochrane review from 2009. Increases retention and treatment, decreases opioid use. I think last week there was another review that just came out in the British Medical Journal showing similar benefits of methadone in terms of a number of outcomes, including mortality, So decades, injection, drug injection, crime days, HIV, seroconversion, employment, health, social function. It really does all of those things. You know, the problem is it's very stigmatized, and the system that we've developed around it really makes it very difficult for a lot of patients to access this medication. But I want to illustrate something for you using one of my favorite studies, and I put this slide as an homage to one of my mentors here at U of C, Dean Gerstein. Some of you may remember Dean. He's now at Claremont University, but he was the vice president for research at NORC for many years, and he used this slide in sort of talking about methadone. So I figured it was appropriate to bring this back. So this is a study done in 1984 in Sweden, a very small study, 17 active heroin injectors in each arm, and they randomized them to two conditions. One condition both conditions got sort of state-of-the-art outpatient counseling, and one arm got methadone treatment. And then they followed them for 2 years. And what they found was, in the methadone arm, the vast majority of folks were doing well. There still were a couple people using, here, one in prison. But the vast majority of people in the non-methadone arm had gone back to using. A couple were in prison. Already there were 2 deaths after 2 years, and 3 major complications: sepsis, which is a blood infection; endocarditis is an infection of the heart valve; a leg amputation, again presumably from infection. So already some major complications 2 years out. And then there's this one guy who's doing well. And we spend tremendous amount of time and energy and policy effort to find this one guy, because most of the treatment system still is really focused on this modality of treatment, particularly for folks in criminal justice. So how many of you would say, okay, this study is ethical to continue? Anybody? No, it's no longer ethical to continue. This is incredibly statistically significant. And in terms of outcome, again, relatively small study. So for those, you are all statistically minded. So small study, highly statistically significant. So that means what? Big effect. You're a plant. Big effect. Yes, it's a huge effect, okay? Keep that in mind. So yeah, it's no longer ethical. So what they did was they offered the non-methadone group to get methadone, and sort of crossover. And again, the vast majority of them are doing well. And there's one in prison, a couple in prison. These couple of folks are still using. These are the folks that keep showing up in your emergency department, right?
I assume you'll get to it at some point. There is a lot of comorbidity and other substance use and so on among methadone clients. And
That's true.
This is a little sanguine if you had a broader set of stuff.
It's sanguine except for this. Of those who did not take the treatment, there are already 5 dead. Okay? Now you're right, there are other outcomes, drug use, neglect. I mean, we can talk about that. But, I don't know, I'm a medical guy, I like hard outcomes, okay? Death, pretty hard, okay? Just, I don't know, some people do come back, but so they claim. Already, after 5 years, so 5 out of 17 dead, 20-ish%, right? We see this pretty consistently in the data that we see, that the mortality rate is in the 20s. It's incredibly high for this disease. So that's why, you're right, there are, this is a simplistic graphic, but the thing I want you to come away from this with is this is a fatal illness. And it's always been, this is from the 80s, right? It's always been a fatal illness. We're now appreciating, you know, and the news media, of course, is now appreciating that it's a fatal illness because of the population shifts, and we can talk more about that probably during the discussion. But it's always been a fatal illness. And then there's still this one guy, right, here, and these were all men, by the way, in this study, whom we expend a tremendous amount of resources, folks in and out of treatment, trying to find the one guy out of 20 or out of 17 who's going to do well with detox and sort of standard outpatient counseling, while there are 5 who die. So for me, this is a pretty stark graphic. In the 2000s, we have a new tool called buprenorphine, which is a partial agonist. And what a partial agonist does is, like a full agonist, it will increase mu activity at lower doses. And what that little bit of mu activity does is it reinforces adherence. So folks will take the med. Remember, we're reinforcing a behavior. And if it makes you feel a little good, okay, you're more likely to take it. And it has a ceiling effect so that the change in intrinsic activity is very small if somebody uses on top of it. And so, again, that extinguishes the behavior. The other thing that's nice about buprenorphine is because it has this ceiling on intrinsic activity, it's safer. So there's less risk of respiratory depression and other things that we can see with full agonists. And because of that now, it sort of revolutionized what we can do in the office. So now we can treat opiate use disorder with an opiate, and buprenorphine is an opioid. It's a derivative from thebaine, which comes from the naturally occurring in the poppy. We have an option now to actually treat in the office using an opioid. And that's new, because that had been banned for most of the 20th century. You know, we see a lot of studies showing its effectiveness. And this was, again, a review from 2009 showing improved retention in opioids. But what about antagonists? So you'll hear a lot about this, particularly in the criminal justice system, that really, you know, we're afraid of agonists because, you know, it's substituting one addiction for another. They have abuse potential. So what about antagonists? So antagonists are substances that occupy the receptor. They have no intrinsic they don't activate it at all. All they do is block. So if the heroin comes around, it won't displace it. But there's nothing encouraging people to take the med, right? You get none of, remember with the partial agonist, there was a little bit of agonist effect that we saw. You don't get any of that with this. So you take your naltrexone, right here at the bottom, there's no effect. They bind and occupy the receptor, but result in no intrinsic activity. And the problem is, you're right, there's no abuse potential and there's no mu activity, receptor activity, but also there's no adherence reinforcement. So what happens is, when we did studies looking at oral naltrexone, so this is a pill people had to take every day, it had no effect because people stopped taking it. So some smart people said, all right, adherence is a real problem for this. We'll come up with a monthly injectable. So this way I don't have to worry about whether or not they're taking the pill every day. We'll just give them a monthly gluteal injection. For those of you who don't know, this is the gluteus, okay? It's also fondly known as buttock, okay? And actually, I had the privilege to be engaged in one of in the largest study of injectable naltrexone. At the time, it had not been approved by the FDA, so you can't get an IND with prisoners. So this was a study that was actually done with criminal justice involved individuals in the community. Here is somebody getting an injection in the buttock. The issue with it is somebody has to be completely opioid free in order to start it. So, we found our patients had a lot of difficulty even going a week without any opioids at all. And, so 437 individuals were screened. This was over 6 sites, 308 randomized. And then and they were balanced versus usual treatment. And what we showed was, yes, there is some effect, but the experience has been we can get people to take the initial shot, but then they often disappear. So it's a useful tool for people who are motivated and really want to do this, but it's not a panacea. And one of the things you'll hear, particularly if you're working in criminal justice settings, is people selling this as sort of the greatest thing since sliced bread. I do think there is a place for it, and it will be useful, but we still need the agonist tools, the other tools that we have. So incarceration doesn't treat addiction. So forced abstinence does not address substance use disorder. It decreases tolerance, but doesn't do anything about those conditioned responses and memory. Sir?
Why do they have to be completely opioid?
All right. So what creates withdrawal, you'll remember when I gave someone a full agonist, the amount of intrinsic activity they had was up here, right? When you give someone an antagonist, when they have an agonist on board, what you do is you displace the agonist, and they go from, say, 90, 100% intrinsic activity down to 0, and they experience very intense withdrawal. Has anybody ever reversed an overdose? Anyone ever given naloxone, Narcan? You have? And did the person love you? Were they really happy with you? They were thrilled? Did they take a swing at you? It was terrible. So if you remember how terrible I described withdrawal before, if you could envision going from like feeling high to feel high / maybe quasi-normal to feeling incredibly sick like that in a second, that's sort of the experience that folks would have. So if I do that to somebody in giving them their first injection and they experience that, do you think they're going to come back for their second injection? I don't think so. So you have to have them completely opioid-free when you do it. Good question. So the problem is you decrease tolerance and condition, but you're not doing anything about the conditioned responses and memory, and they're still vulnerable to the triggers. And the problem is that there are over 12 million jail releases, 700,000 prison releases, and over 200,000 opioid-addicted folks cycle through the system each year. In most of this country, this slide sort of shows some work we did in the 2000s about what kinds of treatment are available in corrections. Most of it is psychoeducation. There's some outpatient, intensive outpatient, and residential. There is no medication treatment that's being provided in prison. Drug-free treatment predominates. And what we see is concerns about illicit opiate use in detention. There's corruption. There's violence. We hear about people smuggling in Suboxone. We hear about HIV and Hep C outbreaks. And people are all concerned, oh, they're smuggling in drugs. Well, you're making them miserable. If I were smuggling in drugs to get high, I'd be smuggling in heroin, right? They're smuggling in Suboxone and methadone because you're not treating their disease. So most folks in this country are going through forced detox. It's too bad there are no lawyers here to sort of talk about why that's cruel and morbid. But one of the things that I think is most detrimental is it reduces the desire to resume medication after release. So this was done by some colleagues of mine at Brown, looking at forced withdrawal. They randomized folks who are on methadone treatment. So they're on an accepted treatment for opiate use disorder. And the practice in most prisons and jails in this country is we don't do methadone. So you must withdraw. They gave people a choice, either to they randomized them either to continue their methadone or they were forced to withdraw, which again is unfortunately the standard of care in this country. And what they looked at was how likely were folks to go seek medication treatment after they were released. And what they found was the vast majority of folks, the treatment was continued their treatment when they got out. And a substantial proportion of folks who were forced to undergo withdrawal refused to go back for treatment. Why? Because if I get picked up again, and people get picked up for all kinds of ticky-tack technical violations, and they put me in detention, I'm going to have to go through that misery again. Right? Remember that misery, that guy I showed you? So we really have a system that is rigged against effective treatment of this disorder. So we have a system that's really focused on medication-free treatment and really penalizes those who are on medication. So it's no surprise that the vast majority of folks return to custody. And really, this goes against our view of this as a chronic disease. So when you think of diseases like hypertension or diabetes, if you treat the disorder, say with insulin, the sugar goes down. And then if you were to take the insulin away and the sugar came up, your conclusion would be, oh, symptoms return when the symptoms return. Sorry about that. The symptoms return when the medication is stopped. That means the treatment must work. What do we do with substance use disorder? Well, we treat them with methadone, effective treatment, and the symptoms of the disorder goes down. And then we stop the treatment, and people go back to using, and we say, well, does treatment work? Does it really work? This is really the question we ask. And it's really the wrong question. We have opportunities throughout the criminal justice system to induce effective treatment. This is some work we did looking at methadone treatment at community reentry. There were 3 conditions. Individuals started methadone just as they were opioid-using individuals who were in prison were given 3 choices, treatment before release and funding, post-release assistance to pay for their methadone. The funding for their assistance in red only or referral with no assistance. And what you can see very nicely in terms of the percentage who are actually seeking treatment, there's a nice dose-response relationship. And similarly, a nice dose-response relationship doesn't quite reach statistical significance, but certainly a strong trend towards improvement in opioid use disorders. This has been shown in, this is our study, but there have been numerous other studies that have shown similar impacts of being able to treat folks at reentry. We did some similar work with buprenorphine at reentry. It was a 2/3, 1/3 design, and in terms of the length of treatment folks received in the community, there was great improvement, decrease in injection, and again, a very small study, and a trend. There were no arrests in the pre-release group, but again, not enough power to show that. But the fact of the matter is a very small study. Again, other studies have shown effects in the same direction. So, one of the points I want you to come away with from here is there are a lot of opportunities in the criminal justice system for intervention, both at arrest, prosecution, adjudication, sentencing, corrections, and most of the work we've done is in community reentry. And to think that there are a lot of treatments that are going on, and very few of them are actually using effective medication for this disorder, for me, is really a tragedy, because this disease has very high mortality when tolerance is lost. So those of you who've been following this sad tale about opioids in this country are familiar with this. So this is the trajectory of opioid deaths through 2015. When you look at the substances involved, we see since the early 2010s, I think around 2009, doctors started to get smart, and you see the amount of overdoses from prescribed opioids starts to level off. But in the meantime, the amount from heroin and other synthetic opioids has really taken off. And I think the reason we see this is because folks got smart about prescribing. I think a lot of the reason we continue to see this is because they've not taken up the effective treatment of the disorder. And this is my slide, clamping the balloon slide. So when you clamp a balloon, what happens? It bulges on the other side, right? There it is. So when we cut down on prescription opioids, if folks don't have good access to effective medication, what happens? Well, if we send them to prison or detox or medication-free treatment, they lose their tolerance, they relapse to erratic street heroin. We're increasingly seeing fentanyl, and people die. Okay? Sir?
Two things about this picture. One is clamping down has different effects on different people in their addiction careers, and we're preventing overdoses in the initiation aspect by clamping down, although we may have some unintended consequences later on. When you look at states and how they clamp down, it's very hard to see in state data. State clamped down, and there was an increase in overdose deaths that followed that. So this is very plausible, but I don't know.
No, but what you can see, the total number of overdoses don't change. What you see, though, is that the primary substances have changed. It's gone from, we had a real problem with overdoses from prescription drugs, and now we're seeing much more from street sources.
So the street sources are also cheaper, and so I don't know that this is. I don't know if this has been either confirmed or refuted as a sort of in actual data.
Just in terms of the causal relationship, I think that remains unclear.
That's fair enough. But the notion is that if this is not an option for folks, these really are the only options that folks have. That's really the statement. And what we see when folks come back from prison, this is data from Ingrid Binswanger from the state of Washington. We've actually replicated these data in Massachusetts, that in the 2 weeks after prison release, there is a 12-fold increased risk of death among individuals leaving prison. And most of this is explained by death. There's a high risk of other substance-related conditions. But my strong belief, we actually have some preliminary data starting to show this for detox as well, that there's a high risk of overdose in the period after detoxification. And I think it's really because we are taking away people's tolerance. The flip side of it is medication, continuation of medication, again, effective agonist medication, maintains tolerance and prevents death. So this was an early study, a small study, 20 in each arm, looking at buprenorphine versus control. The control group got a 6-day taper. The buprenorphine maintenance group got 6 months of treatment. And what they found was, the major finding of the study was that as soon as you detox people, they drop out of treatment. Most of them go back to using. But the thing about this study that many of us found really interesting was there were 4 deaths in the detox patients, which was, it was not powered again for death, right? But statistically significant. And the reason is,
Big
well,
effect?
huge effect size. Yes, right? 20% mortality. 20% mortality over the course of a year. Huge effect size. I mean, this has been shown consistently. There's been some recent data. This just came out in the British Medical Journal last week, looking at methadone reducing annual overdose mortality to 2.6 per thousand from 12.6, and all cause to 11.3 versus 36 per thousand. So clearly, this is a treatment that saves lives that we should doing more in terms of improving access for folks who are at high risk for overdose, and that includes the folks in criminal justice system. This is a study from Robert Schwartz in Baltimore, in which they looked at the community access to agonist treatment. And what they found was over the 2000s, whereas the rest of the country, overdose deaths have been going like this, as they had sort of a slow increase in methadone and a dramatic increase in buprenorphine access, they showed decreases in overdose mortality. So, in summary, opioid use disorder is a chronic neurobehavioral disorder. I really believe that policies favoring medication-less intervention are increasing mortality in individuals with opioid use disorder, and that it's from a loss of tolerance, especially after prison. And medication is really underutilized in the criminal justice system. Increasingly, we're seeing calls for extended release naltrexone in corrections. And it's likely effective on a short-term basis. But there's a lot of concern about the risk of overdose when it's stopped. So when it's stopped, again, people don't have tolerance. So there's a lot of concern about risk of overdose, and as we mentioned, people tend to stop their treatment early. So you have uncertain long-term outcomes. And I think if we're really serious about doing something about reducing overdose deaths, we need a change in policy and in thinking about this disease to really increase access to agonist medication. Thank you.
Can we go back to the slide just before your summary slide? And let me say first, thank you for this talk, and it's, I think, really important and interesting. So much of the literature has the same conclusion that you just had, that we need to increase access to agonist treatment, but it doesn't differentiate between different agonists and the impact of different agonists and their accessibility to different population groups. So I think this one did that. So it looked at impact of methadone and buprenorphine, right? And what did we learn from that?
Well, there is a rise in
Both
methadone.
helped overdoses, but
Right, there is a rise in methadone. It's a more subtle rise than the rise in buprenorphine, and part of it is sort of the introduction of the new medication. My feeling about this is, we have effective tools. We should be
Right.
using them.
right.
the reasons we're not using them are political and ideological and have nothing to do with the science. And
But my impression is there's more stigma and resistance to methadone than to buprenorphine. Do you think that's right?
that's traditionally been true. But there are patients who need methadone, for who don't do well, who need the structure of methadone, and who don't do well with buprenorphine. Similarly, there are people who do perfectly fine with naltrexone. I mean, I've seen them in studies too. So we need to use all of the tools we have. I don't think you can make a relative statement about the effectiveness. I mean, we do know, for example, in terms of long-term retention, we do know that people do tend to stay, the methadone patients do tend to stay on treatment longer. So it's really the amount of exposure and access I really think is the major factor. So whatever somebody will take, I'm
No, I definitely agree with you, but it seems at some point maybe we can get to the point of differential diagnosis or understanding who does better with what or who might have more success.
there's a lot of discussion about that in the clinical world. You have people, but all of us who do this have seen people, for example, who are on high-dose methadone for years. And the thinking, and this is based on one not very well done study, that buprenorphine is equivalent to a moderate methadone dose, 60 to 80 milligrams. But we've all seen patients on very high methadone doses who've come over to buprenorphine and done fine. So you're right. If we understand better the genetics and the other factors that go into whether one responds to one or the other as we go forward, maybe we'll be able to do that. But right now, a lot of it is trial and error.
There's some treatment providers in the room too.
Treatment providers.
Oh, another.
Go ahead anyway.
So I don't know, but is methadone utilized in other criminal justice systems in other countries? Is it available, and have they looked at what the results are with methadone continuance in other countries where criminal justice populations do have access to it?
That's a great question. I had to cut that slide. Yes, a lot of experience in Europe and Australia with agonist therapy in prison and in transition. As a matter of fact, the WHO does include it as a best practice. So the answer to your question is yes, absolutely.
And it works, and they continue with it. Okay, great, thank you.
This data because it's from our study. But it seems like in the healthcare field that the agonist treatment is becoming more accepted. Just thinking about Medicaid policy, for example, that we found that all 50 states and DC provide buprenorphine. Unfortunately, still only half the states cover methadone. And they do all these silly pre-authorization stuff with buprenorphine. So I'm not saying it's perfect, but at least on the buprenorphine side, there seems to be growing acceptance on the medical side that this is really needed and should be, the policy at least says it should be provided. But I'm wondering, are you seeing any movement on the criminal justice side to say this should be provided? Are there some states that are more forward-thinking about this? I mean, I don't know how much you've been able to
There are a
check.
handful
Yeah.
of states that will provide it for folks already on methadone. There are some states that are experimenting with providing it to other, like Rhode Island, but just a handful. And most of the talk you hear in criminal justice in this country is around naltrexone. People are, and part of that is the market. I hate to say it, but it's the marketing by the pharmaceutical company they're giving out a lot of free doses to jails and prisons to do this. And the in detention results are probably fine, but what we're seeing in the community really is not sort of matching the hype. Interestingly, in our study, in the control arm, a quarter of people ended up seeking agonist treatment. They were randomized to usual care. So you can say, oh, a quarter of folks, that's pretty low, but considering these are, what's available to these individuals in the community, that was pretty decent. But it bespeaks a lot of people sort of voting with their feet in terms of what they want.
Yeah. Just one quick question about it. Have there been any lawsuits or cases or anything to try to push this argument forward that there's enough evidence now that not doing maintenance or agonist treatment is creating harm? So basically saying that withdrawal approach is doing harm to patients. Has there been some movement on the legal side?
There have
around
been
that?
suits that have been set. There haven't been really any that have really changed the practice. Actually recently there was a very high-profile death in Massachusetts, and I think there are a number of us who are hoping that that's going to lead to a change in policy around this. But you have to realize if you're going to do this, it requires a whole change in the way medication is dispensed, because these are controlled substances, and oversight and medical staffing, and and the correctional systems already are stretched. So I think an important problem, but not an easy problem to solve.
It brings up sort of the issue of cost. You talk about political and ideological drivers that keep antagonists out of corrections, but it sounds like cost is also a reason why the prison system especially is not taking up antagonist treatment, which begs the question of whether there have been cost-benefit analyses.
So we're talking about agonist treatment, and there actually have been studies looking at it, and most of the costs for society in terms of when you treat somebody with agonists, most of the savings are in criminal justice costs. There have been estimates, for every dollar spent, actually Dean, who was my mentor, who was here, right, did some work with the state of California, and it was sort of a widely cited study that showed for every dollar they spent on treatment, they saved $6 in costs statewide, largely related to criminal justice costs.
I assume that was community treatment and not treatment in corrections.
Right, but we see the same effects in community corrections. I mean, and the problem is when people cycle through the system, as I mentioned, when they cycle through the system, they're less likely to, if they're going to know they're going to be taken off their medication when they enter jail, they're going to be less likely to continue the treatment in the community.
I think you, Gabrielle, the last question.
Gabrielle, last question.
How does the phenomenon of for-profit kind of prisons interact with the Department of Justice and their maybe potential, embracing of agonist treatment or not, or rejecting it?
It's an interesting question because a lot of them do the medical care. Some of them do the medical and the mental health care and behavioral health care. In some places, it's split out. So it's really incredibly varied. That's the other thing about the correctional system that's so fascinating. You've seen one correctional system, you've seen one correctional system. That's so it's incredibly varied. If you're and I've actually had a couple discussions with correctional officials, they have to, when they're thinking about what constitutes effective treatment, what they contract for is what they're going to get, right? So we've had a number of discussions, for example, in Massachusetts, in Hampden County, with probation and parole in terms of what do you contract for? Do you make sure that they have medication available to folks? That has not traditionally been a priority. So you're going to get what you put out for bid. Part of that is sort of, as they say, changing hearts and minds within officials. But the issue is that a lot of the folks who go into sort of the mental health and substance abuse side of this, come from this recovery-oriented tradition that has traditionally been resistant to thinking about medication. So I'm not answering your question, but it's certainly something that a lot of folks are thinking about. Thank you all very much for coming.